In 2012 ACC meeting, long-term results of partner trial were presented, and could you briefly summarize the potential clinical impact of this trial?
Yes, we presented the late follow-up from the partner trial. All patients were followed for at least 2 years and many for 3 years. There were really 4 lessons from that presentation and from the study at this stage, and they're summarized in a new manuscript in the New England Journal of Medicine. First, the mortality difference between surgery and transcatheter AVR was the same. So there was continued equivalence or non-inferiority of mortality, which is a good sign. Second, valve durability. The valve performance was very good, at least as good as the surgical arm, and that makes us feel a little bit more comfortable about the possibility of the new valves being less durable. Third, the stroke problem, which we saw earlier, seemed to be less of an issue as we followed people longer. There was a non-significant difference in total stroke rates when we followed people out to as long as 3 years. And finally, paravalvular regurgitation, which is more common with TAVR, was associated with higher mortality. So that is one target that we have to improve in the future. So there are many clinical lessons from these findings that will help us to make TAVR better.
And please tell us about the current limitations of TAVR devices.
The current limitations of the devices are still the profile, the size is too large. Still, positioning of the device can be difficult for many people. Because the device is large and these are elderly patients, there are many vascular complications which we have to improve. We discussed briefly the issue of strokes, so we have to find ways to be able to reduce the stroke rate. And the current devices do cause, in a high percentage of patients, some degree of paravalvular regurgitation, which is associated with increased mortality. So in the future, there are many new devices and improved techniques, I think, that will make this procedure better. Smaller devices, fewer complications, fewer strokes. So I'm confident that in the future, these limitations can be addressed with more experience and with both improved stent valve technology and accessory devices.
And would you explain to us what dedicated left main stent is, and when do we need the dedicated left main stent?
A dedicated left main stent really applies to the distal bifurcation of the left main, which is 70% of the lesions in the left main involve the distal bifurcation. The current cylindrical stents really are only designed for a single vessel. When you have a complex bifurcation in an area as important as the left main, it may be better to have dedicated devices that are more adapted to the anatomy. So there are many that have been developed right now, and in complex, true distal bifurcation left main lesions, some of these devices may have benefit compared to the current single stent or 2 stent techniques.